Good afternoon, everybody. I am Jason Astin, Director of the Advanced Practice Provider Services for the US Oncology Network. Thank you for joining me this afternoon as we talk about APP utilization, productivity versus value. And I thought what we would do to make this time valuable to all of you is we would review very briefly what I consider a best practice around APP utilization, talk about how some of those challenges translate to both issues around productivity and value, and then get a little bit more detail around productivity versus value and some thoughts around how we can apply that to our APPs. And so way back in 2007, ASCO looked at the potential shortage shortage of oncologists, looking at a supply and demand, and they developed an advisory work group, if you will, who came up with several recommendations. And I highlight a couple of these on a lot of the presentations that I give around my network and outside of the network. One is their recommendation way back in 2007 was to increase the use of APPs. So clearly our largest society recognizes the value of adding advanced practitioners to a practice. And that was kind of their number one recommendation back then. And then that third bullet, I think, also has a lot of relevance for us. And that's how to, and we need to, improve the efficiency of care delivery and certainly opportunity for APPs. So what happens when an organization really does not fully realize potential of adding APPs or utilizing APPs to the top of license or through some best practice is really can become evident in two areas. One is around profit and productivity. So if we look at, in this example, you see $49, which is the amount a group loses in revenue when a physician performs a 99214 versus an APP. And I think it's an interesting illustration because we look at the cost of that physician and we figure out how much they cost us per minute. And we do the same thing for the advanced practitioners. You can see that from just a cost perspective, that the advanced practitioner is likely going to make profit and earn profit from providing a 99214, where a physician actually loses money, and the net effect is a loss of $49. And so the point of that is we want our organizations to recognize that if there's opportunity for APPs to provide evaluation and management services instead of a physician, then we should take advantage of that. But equally as important to recognize that we don't add APPs to practices to completely replace a physician. We add APPs to practices to add additional value, additional services to those patients that are already part of the practice. Another number is around work RVUs. So practices, and in particular, a medical oncologist will lose about 2,500 work RVUs a year when they work independently without the help of an APP. In our network, our APPs probably generate around 3,000 RVUs on average, work RVUs on average. The other big bucket of not fully realizing this potential is just turnover. So if an APP isn't really set up to succeed, the relationship and the culture isn't there, they're going to leave. And multiple surveys that have been replicated still suggest that in a one-year period, about 20% of APPs are expecting to change jobs. And we track our turnover month over month, and our data has been trending down for the last several years, and that's because of a couple of other things I'll mention later on. And it's also costly to not have an APP present when there was one there before. So it's about $1,500 a day that will cost a practice for having a vacant APP position. And if you think about the cost of turnover in total of replacing an APP and hiring a new APP, it's about $250,000 when you look at the credentialing costs, the opportunity where a new APP probably isn't seeing the volume of the APP that left, and all the other ramp up and onboarding that goes with that. And so we look at how APPs are utilized in the practice really with two models. There's the status quo model on the left, and then this new model. And I struggle sometimes with continuing to call this new model, because I bet a lot of you on this, listening in, are already doing this. And so it may not become, it may be kind of like, well, it's kind of new, but there's still probably some practices and organizations that could start to transition. The status quo model is kind of the traditional physician-dependent model, where the APP the APP's role in that practice is determined by the physician. Even the patients that APP sees in a given day are determined by the physician. So think, one big double booked schedule, and in the morning there's a huddle with the physician and APP, and the physician is randomly offloading patients that they think the APP can see. And you can imagine the challenges to that. One is the patients are assuming that they're on the physician's schedule, and then if they're not used to seeing the APP or questioning why they have an APP coming in. And then from an APP perspective, if the patients that they're seeing on kind of randomly are not on their schedule from time to time, they're all kind of new to the APP. And so that really slows down the process, and the APP feels behind when they're trying to, to deliver good continuity of care. So the better recommendation is to have an autonomous or independent APP role that's yet still collaborative. So the APP is independently seeing patients in clinic simultaneously or otherwise. If the physician's at another location or at the hospital, it doesn't matter. But APPs having their own clinic, having their own schedule, having their own nursing support staff, rooms, all the things that everyone needs to manage patients in the clinic. And together, the physicians and APPs are collaborating on patients that need to be, but the APPs are working autonomously. So that's certainly the direction that we like to see our practices head. And when we start talking about kind of this new model, particularly to a physician audience, we tend to hear kind of the same pushback. And the number one concern we hear is basically around kind of a competitive nature of the APPs are going to take my patients. And we certainly then stress that, as part of a care team, and the physician certainly can manage or lead that care team, the APPs are typically just seeing patients that are already seen by the physician. So we're not competing with them for consults. We're just providing additional services and follow-up services, supportive care services, all the things that you're doing to the patients that are basically already existing patients of the practice. We still sometimes hear some pushback around APPs aren't prepared to be providers. They don't deliver high quality care. And that's been disproven in multiple studies over many years, that the quality of care, the level of care that APPs provide rivals that of a lot of physicians. And in a lot of these studies in academic centers outperformed and was higher quality than the residents and even the fellows. I threw in number 4, where APPs should not have the same voice in the group as physicians, because I think as practices are developing their APP programs, and particularly if they're having these discussions around value, it's important that there's some leadership and governance within the APPs in that practice. And so there really should be an APP that's at the table with the board of directors of that practice or other leadership. So they should have that same voice. And we solve that, and we see this pretty regularly in my practices. I survey the APPs just about every year. And one of the questions, I have a laundry list of topics and ideas that I ask each APP to rank in order of importance that would lead to their greater satisfaction at work. And the first couple every year always, I wish I had more money, and or I wish, I had more time off. But one of the top 3 every year is that I want to be a respected part of the team and feel that that's the case. And I share this a lot with our practices as well, both in our network and outside, that this is a very big driver of engagement for your APPs, and it didn't cost anything. So a lot of times practices will push back and say the APPs are asking for more money or more time off, or they want something more. In this case, we're just saying, let's make them part of the team, make them feel like they're part of the team. It's free to do that, and you'll get a highly engaged APP workforce that is likely to stay in your practice. So kind of from a best practice deployment perspective, there's kind of 4 buckets that make sense, that both adds value and of course retention, which is what we're also after as well. The first thing is to develop an APP program that aligns with your organization. So too often we'll have physicians within an organization reach out and say, we want to add an APP, or I want to add an APP for this particular reason. Their partner down the hall also wants to add an APP, but for completely different reasons. So you have multiple APPs kind of driving down different pathways, developing different programs, adding different things to the practice. And it makes it very confusing and tricky for the APPs who are trying to work together as a peer group, and they see discrepancy in practice. And it's hard even to onboard and value, whether it's an evaluation, whatever the metrics might be, to assess kind of the success of the APPs if every APP is functioning differently. So my recommendation is always that APP should be hired and deployed based on an organizational metric or thought process. And it doesn't mean we're all going to be robots and do the exact same thing. We get that there's going to be nuances, but that makes it really easy when we think about how we can train our new APPs together so that we're not doing one-off onboarding and training, and how we can hold them accountable for their performance. And APPs, I hear from most, a lot of times that they're not getting formal evaluations, there's not a formal review process. And so they want to be held accountable for work that they're supposed to be doing. And it's hard to do that if there's different objectives for each APP. And of course, giving those APPs, leadership opportunities as well within that practice. So, and we think about, I'm not going to go through everything on this slide, and you're all doing all of this work, but when we look at APP roles and notice that these are organizationally driven, there's kind of really three buckets that I lump everything into. And the first two from the left and then the one in the middle are both opportunities where the APPs are adding value back to the physician. So they're able to increase physician productivity, increase capacity for physician to see patients, reduce days to a first appointment. And you can see that's things like offloading direct patient care. So that's follow-up visits, supportive care, working off separate schedules like we mentioned. And ideally, a best practice is one APP can support two physicians, which is a good ratio to try to strive to. There are certainly a lot of APPs that support just one physician. There are a lot of APPs that support a whole clinic or a whole site. So there's no really right or wrong answer. When our APPs are starting out and ramping up, we like to then partner them if we can with one or two physicians, because you can imagine supporting 6 or 7 physicians and the nuances there when each physician does something a little different. And you have to constantly remember which physician is this patient belong to. And I know they're going to treat, CINV this way versus their partner. And so supporting two is manageable, and two physicians can usually keep one APP pretty busy. There's a bunch of administrative tasks that can be offloaded to the APP as well, and particularly thinking a lot around value-based care, whether it's OCM or other models. And APPs certainly are also in a position to help supervise some of the other clinical staff. And as you all can attest, the relationship that the nursing staff and medical assistant staff has with the APPs in the practice is usually a little different than it is between them and the physicians. And then there's an opportunity to expand services, whether it's around quality, adding value from a patient perspective. That's providing these additional services you see in this right bucket. And these don't even require the practice to grow. These are providing value added services to the existing patients that from a patient perspective is very important to them. And it's another great opportunity to involve APPs into the practice. There's always going to be challenges, and that is, there's a lot of data on this slide. I'm not going to go through all of it, but my favorite diagram on this slide is this physician APP partnership. And you can read on your own some of these other challenges around making the business case and how do you support, how do you measure metrics and how are you recruiting APPs and how do you even get the patients comfortable to see the APPs. So there's certainly challenges that continue to exist. But I always show this chart here, this diagram on the top right to a lot of our physicians, and we see this all the time. So the decision is made typically based off of one physician's kind of thought process of hiring an APP. They pair up and everybody's happy, and so far so good. But then because the practice doesn't know how to support that individual physician, and maybe the individual physician wasn't really clear on what they expected or thought of the APP or what the APP would do, they become uncertain. And so that APP is scribing and shadowing the physician for a while. And the APP feels inside that this feels wrong and senses that they should be able to be seeing patients more independently. So they're becoming more uncertain about what their role is and why they were hired. And that to the physician sometimes, because they're not communicating throughout all this process, to the physician now they're concerned that this APP lacks confidence, doesn't have the training, doesn't have the expertise, and now I'm certainly not going to let them see patients. And it's just a vicious cycle, and ultimately the APP leaves. And we see this a lot. And so this is a really good opportunity to bring in the consultant into the practice who can kind of look at that culture, look at that relationship, and make recommendations on how to improve that. And clearly having the APP practice from a top-down approach, from an organizational approach, can stop a lot of this before it starts, because we make sure that the physicians are really clear on their expectations of what they're going to get with the APP, what the APP is going to do for them, how long it takes to onboard and ramp up an APP, and so forth and so on. So getting into then metrics, and so really are the current metrics that a lot of us use adequate to demonstrate the value of our oncology APPs? And I'll add that it's important because what a lot of practices do is they measure the success of their APPs the exact same way that they measure their physicians. So it's very easy with a physician to print out a spreadsheet and there's a bunch of dollars and cents. So the physicians are driving consults, they're driving drug charges, they're doing surgeries, whatever the case may be. And so it's volume related. It's easy to generate that productivity. And it's more challenging, and we'll go over some of those barriers in a moment, but it's more challenging from an APP perspective. So if we measure APPs like we do physicians, then we're undervaluing the APP, because the APP naturally probably won't look as profitable as you would expect them to. And our practices, and we've been rolling out a number of incentive opportunities and plans within our practices to help incentivize our APPs, and more importantly, to reward our APPs. And a lot of practices naturally just want to reward productivity exclusively. And we've been trying to kind of shift the mindset to think about other ways that APPs add value, which isn't as easy as just calculating a dollar amount. And we'll go over those in a moment as well. So when you think about APP practice, in a low number, 30% of work that we provide is unbillable. And I've seen in some cases that is actually up as high as 38%. So a number, so even if we go with the 30% number, that means that of our day, if we're being measured exclusively on productivity, we're only capturing 70% of the work we're doing. What else are we doing? That's the rest of that 30%. We also have little control over our volumes. Most of us are not building the practice. Some of us are, and I get that. But in the majority of cases, you require the physicians to see patients as consults, get a treatment plan started, and then refer that patient back to you, whether it's for chemo education or advanced care planning, or start with supportive care and toxicity and follow-up, things like that. So we have little control of volumes. So to hold that metric as the metric we get measured on, hold it over our heads, isn't really fair for the APPs that really don't have a lot of say in what that volume looks like. From a billing perspective, if you're in the clinic and billing incident 2, where you bill under a physician, or in the hospital taking advantage of split shared service, both of which are programs that we should be taking advantage of when the opportunity and the criteria are met. But if the back office kind of billing platform isn't really able to document who performed all the work versus who's getting the billing, it's very easy to remove the APP from the equation, and the APP in essence gets hidden by the physician billing. And so we've lost tracking, or the ability to track revenue from the APP. So it's something that you certainly want your business office to be able to parse out, is whoever billed doesn't matter, but who performed the work is important to keep track of. A lot of our value-based care programs that we want our APPs to lead, things like survivorship, advanced care planning, distress screening, pain management, hospice utilization at end of life, they're not lucrative services from a revenue perspective, but clearly very valuable. And we want our APPs to lead these services, but a lot of our APPs could just as easily come back and say, why would I spend an hour doing a survivorship visit when I can see 4 sick patients and probably earn more? So from a productivity, if you're motivating me to be busy, I'm not going to do anything that's kind of value add that just takes more time. And so we certainly don't want to drive that impression into the APPs. We want them to be recognized for leading on these programs that certainly bring value and quality both to the patient and to the practice. So kind of where is the value? And these are some of the things that we track, and we haven't solved for it completely. As you can tell, it can get pretty intense. But there's a lot of things that the APPs can provide to a practice that we can measure. So you can look at, from a physician perspective, their increased capacity. So if we're able to offload follow-up patients off of the physician schedule, and that opens up a certain number of consult slots, and we can fill those consult slots quicker without stress to the practice. Because I'll tell you, a lot of physicians always say, well, I'm going to hire the APP, maybe, yes or no, but I never turn down a new patient. So if one of my referral sources calls with a new patient, I'm going to work them in. But then we say, yeah, but it's not so simple. You might walk in the room and see that consult sitting there, but behind the scenes, the office was stressed out because now you have a new patient with no records. You have to get hospital records, referral-based records. Maybe there's pathology reports, imaging. It's a whole process. And so we can increase capacity, but at the same time, continue to keep the practice stress at a minimum. Then there's a lot of value that the APP brought. We also can calculate things around time savings, and we do this a lot for our surgeons. So if an APP is providing services in a global period, and so while there are work RVUs being generated, there's no revenue being generated from that particular visit, we can show that why would the surgeon have to do that if the APP is there and we're giving back a certain amount of time to a surgeon, and they can figure out what that time, what can they do? Could they have another, OR day? Could they see more consults to build those OR days? Certainly around value-based care, which I mentioned, and I think it's important that APPs still lead a lot of the initiatives around value-based care. And I think that should be valuable. And I think, we measure our APPs scores. So all of our providers, whether you're a physician or APP, it's easy for us to obtain their quality metrics around distress screening, pain plans, things of that nature. And that all feeds into those AP-led programs as well. And I think the big point is that, there's a life-work balance implication. So, and this would apply to anybody. So if I'm talking to a physician, it goes back to what I just mentioned earlier, where the physician has more capacity with less stress to continue to grow the practice. And that continues to add to that joy of medicine for them. But also the less stress part has implications for your schedulers, front office, check-in, nursing, and even from the APP perspective as well, if we're being valued and being evaluated on the work that we're doing and not just being busy, I think that leads to a lot of success. And again, the goal was really retention from the APP side. So hopefully we went over a bunch of material in a short amount of time, but a lot of updates and hope maybe review on kind of what I consider best practices on APP utilization, and really talked a lot about kind of productivity versus value and where there are some ways to start capturing value in your practice. So hopefully a couple of pearls came out of this you can take back to your practices. This is my email address here, so feel free to reach out if you have any questions or any follow-up thoughts or concerns after this program. But thank you for your attention and hope you enjoy the rest of this course.